Good afternoon, and welcome to the Medical Wisdom Project's YouTube channel. And welcome to another video in our series on medical decision-making with Dr. Bob McNutt. I'm Ed Morgan, founder of our Medical Wisdom Project. Our purpose in this series is to teach you a skill you might not even know you need: how to be a confident patient in today's medical world, how to evaluate your doctor's advice for wisdom, how to choose between options you're offered by specialists, how to find real research from unbiased sources, and how to separate the outcomes, the wheat from the chaff, and how to really understand the concepts of risk and benefits, all this and more. So today we have our friend and colleague back with us, Dr. Robert McNutt. Bob's been in medicine for over 35 years. He's practiced as an oncologist and been on 2 medical school faculties. He is currently teaching and writing at the University of Arkansas. His book, Your Health, Your Decisions, is available on Amazon. So Bob's somewhat startling and liberating view of medical decision-making is that almost anyone can learn enough to make wise medical decisions. So what are we going to talk about today, Bob?
We're going to talk a little bit about decision making. We're going to just start unfolding this whole process of decision making. And it's a complex one, not so much from how you go about learning to make a decision, but becoming to believe that you can, and overcoming the biases of expertise from your physician and the world around you and all the ads and all the things that you face in your life, all the conflicts about making decisions, control from kind of a scientifically based process for making choice. And it has always been my belief that patients can do it. It is that the reason I have that belief is I've watched people do it. I'm an oncologist. I've been, you said 35 years. I wish it was only 35 years, but it's been longer than that, unfortunately. But or fortunately. But I've watched patients make tough medical decisions, and I took the stand that it was their ability and their right to make those choices, because medical decision making requires a balance of some good things to be beneficial to you and some things that you're harmful to you. And that balance, that benefit and risk or harm trade-off that is required of all decisions, because all decisions are comparison. They're comparison of one intervention versus another, and that engenders a difference. Some will have added benefit, but will also add harm. And since I can't balance those things for a patient has to learn to make those balances. And so it has always been my belief to let patients decide. And that's what I do in my practice. For the last 25 years, I haven't given a decision to a patient. I've asked them to participate, sometimes an hour longer. We go over the process of making a choice so they can get comfortable with making them choice themselves. Now, that's interesting and fun for me in a one-on-one with patients. But the real question can be, can we teach that process to everybody else? So this last year, I had a phenomenal opportunity to actually go to a class of undergraduate finance majors at the Walton Business. And I said, I'm going to teach you guys how to understand high quality information. And I'm going to teach you a recipe or a process or an algorithm or approach to science-based decision making. And that was not just in the field of medicine. It was the field of business and it was the field of law. They had to solve cases in all those domains using a process. So I taught them the process and I thought they learned it. At least when I final exam, they wrote down all the important elements that are required to make a highly informed science-based decision. But biased. I liked those students. They were fun to work with. And I may have overestimated their abilities. So I took the opportunity one day because of a man you're about to meet, Mr. Ken Allen, who's a remarkable guy. Um, he's the head of or part of a team of people that is very interesting in continuing education. He's an economist. He's a teacher, a superb teacher. And I invited him to the class for me to go through a medical decision with him to show the class kind of a process. But I will tell you, Ed and Ken, that on the way to the class, which was common, I would change things sometimes between the bathroom and the classroom. And because I would sense something in the student, I decided to let the students interact with Ken and go through a decision. And the decision that Ken and I set up was to whether or not to undergo screening with a CT scan, computerized tomography, for lung cancer in a person who had formerly smoked. Now, Ken had never formerly smoked, but he was playing the part, and he walked into class. I chose a student to inform him, and I invited, and Ed invited Ken to this podcast to give us a sense of what it was like to be informed about lung cancer screening from a undergraduate senior at the Walton College of Business. So I'm going to introduce Ken if he will come on for a minute.
Hello, Bob. Hi.
Ken, do you have a couple comments before we start? Tell us a little bit about yourself.
Oh, I spent most of my career in Dallas, Texas as chief financial officer of a publicly traded company, uh, and am happy to be back in Northwest Arkansas where I got a chance to meet you.
Yep, lucky for me. Um, Tell me, Ken, you walked in and you sat down and you presented the case to a student named Luke. And
Hmm.
what happened after that from your perspective?
Yeah, I wasn't sure what I was going to be walking into, of course. And I tried to keep just a totally open mind and seeing what would happen here. And the first thing that caught my attention was how engaged not just Luke was, but all of your students in this process here. And Luke did a good job of setting the stage and informing me what we were going to do. And he made it easy to progress and go on through the exercise.
Yeah, great. Can you remember some of the things that he talked to you about making the choice? What kind of things did he offer you or tell you you had to do to make the choice?
You know what I remember he really stressed was that I had to make the decision. No one else could make a decision for me, and that he was there to provide evidence and information. But at the end of the day, I had to be the one to weight the pros and cons of taking the CT scan, and it was totally my decision to make. Which you were right in your earlier discussions, both of you. It's a little intimidating to think about that when you've got uh, someone, a doctor or a specialist who really is the expert on something like this. But it was a fascinating exercise.
Do you remember he told you that you had to make a comparison and the
Uh-huh.
comparison with CT scanning versus not? Do you remember if he told you what the screening procedure was?
A lot of CT scans result in a question mark that requires next steps and things like that. That can take you, my terminology now, okay? My terminology, almost down a rabbit hole that can have some uh, pretty costly or risky results.
Yeah, he got right into that for you then.
Yeah.
You could see very quickly within it, he had presented that there was going to be a trade-off. Was that true?
Yes. I mean, there always are in decisions. My background is in decisions, and any decision that is important always has trade offs, and particularly in health.
Do you remember the first trade-off he discussed? Was it about the quality of the test, or was it about the effect on outcomes?
Uh, I I can't remember which. We did talk about quality of test, but what strikes me more than anything is the outcomes more than anything else, and what uh, that's what we needed to focus on, or what were the outcomes, and what were the risks associated with each outcome, and what was the potential positives as well.
Awesome. So that is a very important characteristic of making decisions, is being able to weigh benefit and harm. And for cancer screening, especially with CT scan screening in people who potentially were smokers or quit smoking with a short period of time, the idea is, will it save lives? And there are two components of comparison. One is the value of the test, which is how likely is it to detect the cancer? And the other side of it is, it'll miss it, right? So you could get a test and be falsely assured that you don't have cancer, but the test could. The other side of that coin is that you could get a test, and because the CAT scans doesn't tell you what's there, it'll see an abnormality, and now you got to go down a few more steps to find out whether it is a false positive, or scary kind of a thing that before you know whether you got cancer or not, you got to go down several other things. He did discuss that, didn't he?
Yes, he did. Did a good job of stepping through everything in a way that even someone like me could understand.
Yeah, he did it. Did he ask the crowd around him to find data for him?
Oh, that was so much fun. You could tell people, students are connected to their iPhones anyway, okay, almost symbiotically. So go out and find this data to help Ken make a decision. And it was almost like a race among the students to see who could come up with the information the quickest. They did a good job.
And how quick was it?
Oh, I, within a minute, it seemed like to me. Yeah.
Well, I told him how to search the medical literature, and even for some of their business and legal cases, to get to quality information within a very short period of time. I was amazed how quick they were. When medical literature, if you put in PubMed at the end, pubmed.gov, you'll get data right out of some of the highest quality literature. They were finding it and spouting it out. They were competing, weren't they?
Yeah, they were. It was almost like an auction.
I love it. I love it. I love it. Yeah, I didn't give out any award points for any of it, but do you remember at all any of the numbers?
I'm an old man, Bob, and I can't remember the numbers too much. I hope you have them there, but they really did a good job of delineating them in a chart form or a table form that was able, again, it was something that was easily understood. If I were really a patient and a physician or an expert put those in front of me, the students did a good job of putting those in front of me in an understandable way.
Do you remember, did they tell you that you had time to make this decision? That you didn't have to rush to judgment? Do you remember that?
Yes, I sure do. Yeah, which was important, right?
Yep.
Somebody tells you, you might have cancer or something. You want to either you run from it as far as you can, or you attack it as fast as you can.
Yeah.
And they did a good job of making making me understand that we really just didn't have to move quickly.
Well, Ken, thank you very much. I wanted the people to hear that it's not me that believes that people can learn the process of making a choice and informing others of it. Some of those students are so good that I'm dealing with them yet today. I'd love to someday hire them to be nothing but information managers for people with tough decisions in business, law, and medicine. I do not think you have to be a doctor to be informed, but there has to be some also understanding of the quality of the information. And we didn't get to that, but I will tell you the first half of the class included what is a probability? What is a likelihood ratio? How good is
Yes.
it? Where do you get it? What can be the problems? Statistical issues, epidemiologic issues. They became pretty sophisticated. Some of them became good skeptics, right? They were, that's what I was aiming for, not cynicism, but skepticism. And I think you're affirming that I felt very happy and comfortable that they had gone a long way down the process.
No, you're right, and not only that, you really sparked their imagination about how to use some of these processes in the rest of their life, I think. And that's a tremendous accomplishment, I think.
Yeah, if we did that, that was one of my goals and aims. I don't know. I couldn't find anything about how do you teach people to turn them on, but I used every technique I could. Like I said, I would sometimes change going down the hallway on what I was going to talk to them about. You have to be pretty facile. You have to be on your feet. Um, we do this again. We're going to do videotaping and audio taping of the class. So, and I'm putting together a whole series of learning things for like a syllabus kind of book thing so that we can teach this to a broad array of students. In fact, I'm meeting with some high school people that I think that you can teach these process right down in high school. Because my dream is that if we had an informed public, we'd have a very more equitable, fair, and a better outcome-based decision process and a better healthcare. I've always said we need decision reform, not healthcare reform.
Hmm.
And the people themselves can become a very strong advocate because their conflict of interest is on them and no one else. So I really appreciate it. I think the next podcast we have, I'm going to summarize the process. And
Okay.
I actually may go through a CAT scan decision for lung cancer screening with someone to just go through exactly the process, getting rid of bias, looking at it neutrally, understanding what the implications are, what's the possible benefit, what's the harm, what's the trade-off, how to help them through that process is something we didn't get much chance to do with you, Ken, but we got to the point of being comparison, benefit, harm, taking your time, being the advocate for the decision maker rather than the decision maker was something I tried to teach them through the class.
Oh, again, just the level of engagement they showed while I was there is proof of all you've just said.
Well, thanks, Ken. Ed, you want
Yeah,
to come back? You have some comments?
yeah, you just got my curiosity up. So what happened? Was the recommendation to scan or not?
Oh, Ed, you've got a lot to learn. Didn't you just hear that we don't make recommendations, we give you data. And the
Yeah,
data are, I've got it right here in front of me. It's fascinating. There have been 7 randomized trials, 27,000 people in each trial. There was only 183 patient differences in the mortality for less than a 0.5% difference in lung cancer mortality at 10 years. 3%
wow.
versus 3.5%. That's a 0.5 percentage different over 10 years. So
Whether you take the scan or not, is that what you're saying?
if you take the scan versus
Yeah.
there's a 0.5% difference at 10 years in lung
Okay.
cancer mortality. But the problem is that's out of 28,000 people, the confidence intervals around those, which we talked with the students, were wide ranging. So the uncertainty is massive. And
Yeah,
to give you an idea, that the harm rate was around 2% every time you had a CAT scan. Go biopsy something. And what people don't realize, they're not talking about one CAT scan, they're talking about 3, one a year for 3 years. And there was actually radiation-induced cancers. So there's a harm, there's a benefit. The benefit, the best estimate is it's about a 0.5%. It's about, let me see, 800 versus 900 people difference in the death rate out of 27,000 people at 10 years. So that kind of a small difference has to be traded off against a lot of downstream potential harm. That's what a person has to decide.
yes. Yes, thank you. Wow. In closing, let me thank you guys. I'm looking forward to the next one very much. And let me tell you how you can stay in touch with us. We have a website, www.medicalwisdomproject.com. We look forward to more series that get even further down into some of the most common decisions that people have to make. Whether to take statins, whether to take a certain procedure or not. There's just so many inexhaustible subjects. So, Ken, you were great to come on, and Bob, this class sounds fascinating. So, with that, we'll wrap up. What else
Thanks
do you?
for what you're trying to do, and thank you again, Ken.
You're welcome, Bob. Thanks, Ed. Good luck in your initiative here. This sounds great.
All right. Goodbye, and we'll talk to you
Bye,
soon.
everybody.